Today, I'm going to share with you some of my thoughts and experiences with osteochondral allograft transplantation, specifically using a lateral femoral allograft to transplant to a defect in a medial femoral condyle. Important tips for success with osteochondral allograft transplantation. The first and most important of which is an anatomic articular surface restoration. The second important point is osseous union with complete replacement by host bone. The third is assessment and correction of malalignment if present. The lateral femoral condyle is a suitable source for osteochondral grafting for several reasons. The articular surface of the lateral femoral condyle is thicker than corresponding sections of the medial femoral condyle, except in the sulcus terminalis. There's also evidence that would suggest that the cartilage in the lateral femoral condyle is stiffer and stronger and more resistant to surface propagation cracking. The data at Joint Restoration Foundation would indicate that 75% of the requests for osteochondral allograft tissue is for a medial femoral condyle. Approximately 75% of the grafts that are made available are lateral femoral condyles. We have been transplanting osteochondral allografts from lateral hemicondyles to defects in the medial femoral condyle for over 10 years with documented success. Oftentimes you have a lesion that's bigger than 20 millimeters, but in most cases that I've experienced, the lesion is longer or bigger in the anterior to posterior dimension. Again, this plug that's in place is from a lateral hemicondyle. So if I have a lesion that is bigger than 2 square centimeters, I frequently will use 2 plugs and will overlap the 2 plugs. And you can see we have a better chance of restoring the articular cartilage anatomically with 2 plugs as opposed to using 1 large plug. We've sized this up. We measured from our defect 7 millimeters in the medial, posterior, and anterior portions of the defect, and we measured 4 millimeters on the lateral aspect. Once a defect is drilled out to a depth of approximately 8 millimeters, the depth of the lesion is measured in 4 quadrants. If all 4 quadrants measure the same number, then we have a symmetric cylindrical defect, and this will be relatively easy to fill with an anatomic restoration using a simple plug. However, if the lesion is off to the side of the condyle and you've drilled out the base, the surface of the condyle may not be flush and symmetric. Putting a symmetric cylindrical plug in this situation will result in a plug that is proud in one of the quadrants. So our harvester needs to be flush on 3 surfaces and up by 3 millimeters on 1 surface. We're going to take a rongeur and just kind of bevel the edges of this allograft. It aids in getting the implant into place without undue pressure. There's a smooth, no step off on the weight-bearing surface, medially, posteriorly, anteriorly, and even laterally. I want to share with you a couple case studies. The first is TB, a 50-year-old man who sustained a work-related twisting injury to his right knee. He underwent an arthroscopy and was found to have a substantial full-thickness chondral defect in the medial femoral condyle. He underwent a debridement and a microfracture and was treated postoperatively with CPM in a non-weight-bearing status for 6 to 8 weeks. Despite this, he continued to have ongoing pain and catching in his knee. Long leg alignment x-rays were obtained, which did reveal varus malalignment. So TB was taken to the OR for a second surgery approximately 6 months after his microfracture. He underwent an osteochondral allograft transplantation to his medial femoral condyle defect, along with a valgus-producing high tibial osteotomy. We used 2 lateral femoral condyle allograft plugs, one of which measured 18 millimeters and the other of which measured 20 millimeters, and the plugs were overlapped on each other. At 8 months, TB was doing well and had returned to all recreational activities and work. However, he continued to have pain along the retained metallic plate for his tibial osteotomy. He was taken to the OR to have removal of the hardware. We asked TB if we could perform an arthroscopy on his knee to assess the articular alignment and the allografts. The images that you see here are scope images that show a well-restored articular surface and intact articular cartilage on the osteochondral allografts. I want to share with you a case study, that of AL, a 17-year-old high school soccer player who presented with pain and mechanical popping along the medial side of her left knee. On radiographs, she was noted to have an osteochondritis dissecans lesion along the lateral portion of the medial femoral condyle. MRI revealed the osteochondral lesion with questionable fluid behind the lesion, consistent with it being unstable and loose. AL was taken to the OR for a diagnostic arthroscopy, and the loose, unstable necrotic osteochondral fragment was evaluated and excised. This left her a defect that measured greater than 3 centimeters in the anterior to posterior dimension. Standing weight-bearing alignment radiographs were obtained and revealed that she had neutral alignment. AL eventually underwent an osteochondral allograft transplant to her medial femoral condyle defect. In this situation, we used a lateral femoral condyle allograft and implanted 2 plugs, one that measured 20 millimeters in diameter and one that measured 18 millimeters in diameter. These plugs were overlapped by approximately 3 to 4 millimeters. AL went on to have an uneventful recovery and did return and play for her high school soccer team. She did finish college and was able to play recreational soccer. However, at 4 years, she came back to visit. And as you can see here, the allografts have both incorporated well, and there's an anatomic restoration of the articular surface. The University of California, San Diego has extensively studied allograft tissue, and they've done work on chondrocyte viability. Their work has directly impacted the availability of osteochondral allograft tissue, as we now can harvest tissue and store it appropriately with implantations as much as 3 to 4 weeks after harvest. I hope you found this video to be enlightening and helpful, and would help you to consider using a lateral femoral condyle allograft for your patients with medial femoral condyle defects.